The way I have it today, we will predominantly be covering insulin. And a couple other related pancreatic hormones and analogs. Should come as a bit of a change from, 50, 60 drugs a day. And next week, we will cover the rest of the drugs that are mostly going to be used for type 2 diabetes. So here are the learning objectives. This covers this week and next week. Content.
Seriously, when you tell me that.
So
Bless you.
as a review, I know to some extent you cover a lot of this, but when it comes to glucose and glucose metabolism, that really is one of the main currencies for energy in the body. Glucose is used by all human cells and as an energy source, but then also has a role in terms of being a precursor for synthesis of other essential chemicals in the body, including lipids, nucleic acids, and amino acids. There are, though, other compounds that are synthesized by the body that's separate from glucose. And in total, your needs for glucose is around 190 milligrams a day. Diabetes is a metabolic syndrome that's characterized by persistently abnormally elevated blood glucose levels. And of course, complications include cardiovascular disease, microvascular disease, neuropathies, nephropathies, retinopathies, other metabolic issues such as hyperlipidemia and peripheral vascular disease. You get to diabetes with, over time, and as I have a slide that shows a bit about that progression, but you become symptomatic when, or the patient becomes symptomatic when they exhibit polyuria, of course, frequency, urination, polydipsia, which is excess thirst. That comes as your brain signals elevated osmoles in the blood. And one of the key things to remember is that glucose is one of the main determinants of blood osmolality. So when glucose is elevated, your overall osmolality is elevated. That will signal to the hypothalamus the thirst response. Because of its role in metabolism, especially type 1 diabetics will exhibit weight loss. Random plasma glucose levels will be typically more than 200, and at fasting, more than 126. Postprandial glucose tolerance is going to be impaired as well, with levels more than 200 2 hours after a standardized glucose load is ingested. And hemoglobin A1C, as you know, is a marker of long-term blood sugar control, is greater than 6.5. You have your different types of diabetes. Type 1 diabetes is a disorder where your pancreas really begins to lose its capacity to synthesize insulin. And that accounts for about 10% of all diabetes cases, and it's typically a childhood onset disease with immediate onset at age 12. These individuals will require, once the diabetes sets in, exogenous or medication insulin to be administered for survival. There is a type 1.5 diabetes where the onset is a little bit later in life, but the presentation kind of mimics type 1 diabetes where due to autoimmune syndrome, they develop this diabetes picture. Type 2 diabetes is more the insulin resistance. You can have normal insulin levels, elevated insulin levels, and that will onset typically into adulthood, but we're seeing now a lot of type 2 diabetes even in younger patients. About 4% of pregnancies will have gestational diabetes. And then there's this intermediate syndrome called impaired fasting glucose, where you're not quite diabetic, you're pre-diabetic, if you will, with blood sugars at fasting between 110 and 125. Again, we talked about a lot of the complications, but with type 1 diabetics, renal failure is predominates, and type 2 is the macrovascular disease, peripheral vascular disease, and some of those other issues. Type 1 diabetics will often have a family history. There's also, and then type 2 will also have some family history as well, but lifestyle plays a bigger role there. Now, the pancreas is the key organ in terms of its role in regulating secretion of insulin, which, of course, is one of the key hormones in diabetes. There are islet cells. These are the cells in the pancreas that secrete these various hormones. Within the islet cells, there are within the islets, excuse me, there are specific cells that will have different roles and different secretory products. So, for example, beta cells, which account for about 70% of the mass for the islets in the pancreas, secrete insulin, also C-peptide, which I'll describe in a little bit, and amylin. Collectively, these are important these are catabolic hormones, so they're anabolic hormones for storage and growth. On the other hand, alpha cells mobilize fuel through gluconeogenesis and glycogenolysis, and their main secretory product is glucagon. Glucagon, in a lot of ways, opposes the action of insulin, but I will also describe that today as a pharmacologic product that's used in diabetics, particularly those who develop hypoglycemia, low blood sugar. There are other pancreatic hormones as well, somatostatin that comes from D or delta cells in the pancreas. Somatostatin is kind of a brake on secretion. It is a fairly broad inhibitor of secretion across the board. There are F cells that secrete pancreatic polypeptide, which has kind of this unclear role in digestion. And then ghrelin is another product from what's called the epsilon cells, and that's involved in energy homeostasis. Ghrelin, think of as the hunger hormone. It's a signal to the brain that will promote food cravings and also prepare the GI tract for digestion. But three products I have in bold here, insulin, amylin, and glucagon, are, we'll say, pharmacologically relevant, particularly in type 1 diabetes. So this is what the pancreatic islets look like, okay? And within those islets, again, there are alpha cells, beta cells, delta cells, etc. But the predominant products are these red, or appear in this diagram as red cells, the beta cells. Beta cells secrete insulin, and alpha cells secrete glucagon. And in diseased pancreas, you begin to see kind of a shift in balance between how these cells are functioning. In type 2 diabetes, for example, there may be fewer beta cells that secrete insufficient levels of insulin, but that's not always the case, because again, you can also have insulin resistance, whereby you actually see increased insulin levels but it's not as effective in the target tissues. There may also be a dysfunction of alpha cells in diabetes whereby there's an inappropriate high level of glucagon being secreted. That will also tend to increase blood sugars. So this is what I alluded to a little bit earlier, whereby over the course of sleep illness, there may be a decline in beta cell functioning, whereby maybe even 10 years prior to diagnosis, there is a decline in the activity of these beta cells. And then once diagnosis takes place, again, the manifestations of elevated blood sugar, polyuria, polydipsia, etc., that may not occur until you've lost already 50% of the function of those pancreatic beta cells. And then, of course, it gets worse as the disease progresses. So again, the key secretory product is insulin. Insulin, though, has a few steps in its life cycle. Basically, DNA codes for a protein called pre-proinsulin. That is what gets synthesized in the beta cells. So this is a precursor to the precursor of insulin. So pre-proinsulin is secreted, is synthesized, excuse me. It is then broken down into insulin and C-peptide. That is what gets stored and packaged into granules and is prepared for secretion. So if the blue peptide represents insulin, and the kind of the pink peptide in this diagram is C-peptide, the two together is proinsulin. Okay. So proinsulin equals C-peptide plus insulin. That is the storage product. As the body senses that glucose is elevated or, whatever signaling takes place, then that combination is secreted in equal amounts. So for every insulin molecule that is released, there's also a C-peptide that's released. Now, specifically around C-peptide, what does it do? Well, we don't know. It probably doesn't have much of a role, at least as far as we know. But if you kind of surmise that, again, for every C-peptide that is secreted, there's an insulin secreted, then C-peptide itself can be an index of insulin secretion, meaning if you can measure C-peptide, even if you're giving insulin as a drug to the patient, the C-peptide will tell you how much insulin is being produced by the body, again, because that amount is going to be exactly the same as the insulin that's being secreted. But anyway, you get both the C-peptide and the insulin that gets secreted. Insulin eventually gets broken down. There are these disulfide cross-linkages here that gets targeted, and that gets broken down to inactive products. The liver clears about 60%, the kidney clears about 40%, and it has about a 3 to 9 minute half-life total. So just a little bit more detail here. Again, this whole process comes as a result of signaling of high blood glucose levels. So in this diagram on the left-hand side here, there's a transporter called the GLUT GLUT2 transporter. Okay, that brings glucose into the beta cell and through an active transporter. And this basically increases the concentration of ATP in that cell. The increased ATP levels closes, these ion channels whereby potassium would normally flow out of. Remember, potassium is very concentrated inside the cell, and it's less concentrated outside the cell. So the passive diffusion of potassium will tend to have it go from intracellular to extracellular. But in the setting of increased ATP, that channel closes. So now you have more potassium in the cell, which then leads to polarization of the calcium channel. And that will lead to secretion of insulin and C-peptide. Now this process, it'll come into play a little bit more next week because the drugs that we take or that we give to secrete insulin in type 2 diabetics, particularly sulfonylureas, will work on these ion channels. Okay. What we're focusing on insulin this week, insulin is just insulin. We're administering it as a drug, and I'll go through all the different dosage forms and routes of administrations and long-acting, short-acting. We'll cover all of that. But really the point of this process is going to come into play pharmacologically in terms of drug mechanisms, more so next week when we cover secretagogue drugs. And those are drugs that basically push insulin out of these beta cells. So glucose transporters, they're important for a number of reasons. Again, the beta cells of the pancreas has a very specific one called a GLUT2 transporter, and that is the signal to those beta cells to release insulin. But there are at least 4 other known glucose transporters. And these are relevant also for not just for insulin secretion, but also insulin glucose utilization. All right. So one of the things that we want to improve in diabetics is, as a goal to reduce blood glucose levels. Certainly we can have more insulin secreted, so that can then lead to reduction of blood glucose. But also, if we want more glucose uptake into the muscles, into the brain, into the blood, into basically various target organs. And these glucose transporters can help facilitate that. If they're active, for example, the GLUT3 in the brain and the kidney, you will get more glucose uptake there. GLUT4 transporters help glucose uptake in muscle and adipose tissue. So, they are part of the story as well in terms of glucose metabolism. All right, so getting back to insulin, that's our focus today. This is a hormone that works to stimulate glucose uptake into target tissues, particularly via the GLUT4 transporter. So insulin basically, when it activates its receptor, it initiates phosphorylation cascade, basically takes that glucose transporter, makes it active, presents it to the outside of the cell, and then that can carry the glucose into the cell through a facilitated diffusion. And now that the glucose is in the cell, it can be stored, it can be used for energy, etc. On the liver, insulin will promote glucose storage. So basically, the liver will take glucose in, and then its storage product is glycogen, which is a very complex formulation of sugar. And it's suitable for long-term storage. Glycogen will be there in a specific amount. You can have, but only so much glycogen, but that will be your storage for energy when your body needs it. The liver can also take glucose and convert it into fatty acids, VLDL, and also fat, adipose. Remember I said at the beginning that glucose can be converted into all of these other products. Right, so fatty acids and adipose, et cetera, the liver will cover that. But the glucose conversion to glycogen kind of keeps it in a form where it's, I would say, fairly readily accessible to be broken back down for as an energy source. Insulin has inhibitory roles in the liver as well. It will prevent glycogenolysis, which is the breakdown of that glycogen into glucose. Gluconeogenesis is the formation of new glucose from other precursors, and the conversion of fatty acids into ketones. So insulin has those inhibitory roles. When you have low insulin, you will actually produce more glucose and produce more ketones. In skeletal muscle, insulin promotes storage of glycogen, not as much as it does in the liver, but skeletal muscle can store some glycogen, as well as taking storage of amino acids as protein. Whereas it has inhibitory effects that are the opposite, which is the protein breakdown into amino acids. And then finally, in adipose tissue, insulin again promotes storage of glucose and conversion into storage product fatty acids, and inhibits the reverse process of converting triglycerides into fatty acids. So insulin is produced throughout the day. It's responsive both to kind of your body's circadian rhythms, kind of your inner clock that is responsive to, for example, sunlight and just normal day-night variation. But then, of course, insulin is also responsive to blood sugar levels. That comes from the diet. So you have a food bolus that will, like I mentioned earlier, signal to the beta cells that your blood sugar is rising. Your body will now produce insulin in response to that. So there is a kind of a basal secretion of insulin and a meal triggered release of insulin as well. So pharmacologically speaking, we basically have a number of different products that are all right now based are produced through recombinant DNA technology. We've kind of moved away from animal-based insulins. They were at a time beef-derived and pork-derived insulin. Insulins from those sources were effective at lowering blood sugar, but because their amino acid sequences varied slightly, there was some antigenicity involved there. So your body would recognize it as foreign. Some people may produce antibodies to it, so you have some of those issues. And we've gotten to a point now where through recombinant DNA technology, we're able to sequence the exact same DNA sequence for human insulin and make it into a pharmacologic product. So basically everything that's for sale for human use is based on recombinant DNA. There's still some veterinary products that you can get derived from pork and beef. Now, what we are able to do pharmacologically with insulin is to alter its genetics. And when you deal with diabetes, you want to be able to have products that meet the needs of patients, real life patients. Patients, for example, that may eat on a regular schedule or on an irregular schedule, that may fast or may not fast, and you need drugs that can be responsive, meaning that if someone has a really large carb load, at a given time. You want something that you're able to give that can cover that patient during that period. Or you have basal insulin, okay, that would mimic the basal insulin secretion that I showed you in this slide here. All right, so there are different durations of action and different pharmacologic properties of modern insulin products that are designed to kind of suit the needs for individual patients. Now, how that gets accomplished, how are we able to modify this very specific amino acid sequence and very specific protein to do that? There are very specific things we can do. For example, we can complex it with zinc. And what zinc does is basically can basically prolong the action of regular insulin. So you can take regular insulin and it precipitates to a certain degree in the presence of zinc. And you can basically take regular insulin and convert it into a longer acting product. And we'll talk about that, although we really don't use zinc in these conversions anymore. You're going to also add protamine. Protamine is another kind of a protein product that can be given to increase the duration. But really, what we nowadays, the modern products, the ones that we use most often, here we are in the 2020s, are insulin analogs. They basically take the human insulin, the amino acid sequence of human insulin, and make one or two modifications so that it's a little bit more customized, again, to meet specific needs, either to be a shorter duration for meal times or longer duration as a basal insulin. All right, as proteins, basically, they're not suitable for oral use, right? You don't see people taking insulin by mouth. So, because of course they get broken down immediately. The most frequent route of administration for insulin, of course, is subcutaneous. All right, so conventionally speaking, the patient will draw insulin in a syringe and administer it up near the skin. But I will talk briefly about an inhaled insulin product, which uses the pulmonary delivery for rapid acting effect. So that's another way to do it. Again, bypassing the GI tract where, of course, your enzymes there will rapidly break it. All right, so here are the products. These are the ones that are currently being marketed. And these are the basic forms. Now, there are going to be some modifications to these in different pharmacologic products, but this is kind of the basic menu we're working on. Regular insulin, branded as Humulin R, which is an Eli Lilly product, or Novolin R, which is a Novo Nordisk product. Both the same, they're therapeutically, and they're basically the same. They're identical to human insulin. They're made from recombinant DNA technology, and their amino acid sequence will be the same as human insulin. The kinetics of regular insulin will give about a 30 to 60 minute onset. After administration, it will begin to lower blood sugar within 30 to 60 minutes. Its effects will peak in about 2 to 3 hours, and its overall duration will wear off at around 6 to 8 hours. Now, again, pharmacologically, insulin, regular insulin is the same as your endogenously produced insulin. Now, if you were following closely, okay, so here I'm showing that insulin has a half-life of 3 to 9 minutes. So there is some differences between the pharmacologic effects, if you can call it that, of your endogenous insulin and insulin that's administered subcutaneously from a from a drug product. Okay, because of, again, some of the absorption kinetics that take place and the release of the drug from its vehicle and all of that. But again, don't let that confuse you. Regular insulin given as a drug pharmacologically will produce those particular parameters. Onset 30 to 60 minutes, peak in 2 to 3 hours, duration 6 to 8 hours. Slightly, which is different, longer than endogenously secreted insulin from the pancreas, even though the product itself is the same. Are you following me? Okay. We're going to go next to our rapid acting products. Insulin Lispro, Aspart, and glulisine. Think of these three as therapeutically equivalent. Okay. Now, as a prescriber, if you write for Novolog, you're not allowed to switch to Humalog or anything like that. They're not AB rated generic equivalents. And you can't substitute that way in the community. In the hospital, if you're on formulary, and they can do that. But basically, they are equivalent therapeutically. They're not the same product. Again, here we're dealing with amino acid substitutions. So, Lispro takes the lysine from B29, I'm sorry, lysine from B28, proline at B29, and switches those two. So let me explain. This is our, oops, I'm the wrong way. This is our insulin sequence here. So if we go to 29, you see lysine here and proline here. Lispro will basically take those two and swap them. That's it. Same sequence, but we're swapping lysine and proline at 28 and 29. That gives you Lispro, okay? What that does in effect, it makes it, gives it a faster absorption and a shorter duration. So therefore, its onset is going to be 15 minutes, basically, 0.2 to 0.3 hours. It peaks in 1 to 1.5 hours, and its duration is 3 to 5 hours. Okay. Faster onset, shorter duration than regular insulin. It makes it suitable as a mealtime insulin. Aspart, we'll take that proline that's at B28 and swap that to aspartate. That's it. Otherwise, it's exactly identical to regular insulin and will give you pretty much the same kinetics as Lispro. And then finally, glulisine will substitute at the B3 and B29 positions, lysine and glutamate. Again, not perfectly identical, but very, very close. And again, Apidra, glulisine, we give, we use the same as a meal types. Question.
Are we gonna be responsible for those?
Not specifically the amino acid sequence, but I will want you to know the difference between, how is it that we're able to accomplish these modifications against what it needs. But no, I'm not gonna ask about what gets switched where. Okay. Yes. Really, the main driver is going to be cost and insurance. Really, I mean, when it comes to tolerability, they're all the same. Yeah. Side effects. I mean, there may be a very rare person that's allergic to one and the other. I mean, I've never seen that, but basically, when I say that therapeutic equivalents, you use them interchangeably based on what their role is, but they might have an insurance that covers one or the other, or you might prefer the Lilly product because they're cheaper or whatever. So that's really the decision as far as that. Or you might be working in a hospital whose formulary product is Novolog and Humalog, and then you pretty much have a choice. Yes.
In terms of level of detail, like, should we just know which ones are longer versus shorter than regular, or should we actually memorize like the hours?
I want you to know what's if I give you a product, you should be able to say what's rapid acting, what's intermediate, and what's long acting. And then from a practicality standpoint, well, what gets used as a mealtime insulin, what's not? The actual specific details, I mean, as a practitioner, you'll get used to it and you will, especially if you work in endocrinology, get really good at timing doses and all that. Yes, you will get good at that, but you can always look that up. Okay. Intermediate acting. Then we have insulin N. This is a bit of an older product. It's been around for a while. This basically takes zinc and protamine. Again, those are certain modifications you can take to regular insulin to make it longer acting. And in the case of insulin N, we now have an onset between 1 and 2 hours. It peaks in about 8 to 10 and gives you a 20 to 24-hour duration. Typically, this kinetic will give you a basal property, kind of an all-day effect, if you give it twice a day. Cumulant N, yeah, it's really twice a day insulin, basically. And then we have longer acting insulins. These are all newer products, which are mostly amino acid substitutions. And these are generally suitable for once daily dosing. Right, so the first of these, and probably still the most popular, is Lantus, which is insulin glargine. That basically takes the glycine on the A chain, 21 position, makes that a substitution. Dedimer puts side chain on B29. Likewise, degludec puts a side chain on B29, and they both delete the B30 position. The long-acting products have kind of a slow onset, and they kind of call them peakless, meaning that it's once its onset takes place, it's pretty much a steady release, giving you pretty much close to 24-hour coverage over the course of the day without necessarily a peak where it has its greatest effects at any given time in that dosing range. Again, long-acting and rapid-acting insulins mostly involve amino acid substitutions, and the cumulant N isothane insulin is a insulin with a zinc protein complex that increases its duration. Question? I will get into that. You can get some people on just a basal insulin. And then as far as mealtime, there's a few approaches you can take. There are, for example, type 2 patients. There are some oral drugs you can give that will cover mealtime. There's another injectable one covered today that's not used much, the amylin analogs that you can use for mealtime. But basically, most people on a newer basal insulin will also be getting rapid acting for meal. Most, yeah, 80%. Okay. So we'll little more detail. Regular insulin. Again, it's considered a relatively short acting insulin, but it's not short enough where it's ideal for mealtime use. Why? Because its onset is too slow, about 30 to 60 minutes. So really, you would have to have your patients know a half an hour before they're eating to dose themselves. And then on top of that, its duration is too long, 5 to 8 hours, really not appropriate because by then, your food is well transited through the GI tract, and you still have this insulin on board that will be causing low blood sugars. So regular is not good for mealtime use. What it is good for, though, is if you have someone pretty much coming in emergently for severe hypoglycemia. Your DKA patients, basically, we're using regular insulin, full stop, either as a bolus or more commonly as a IV drip. We also use it for correction of hyperkalemia. I mean, I talked about this briefly last semester, and I'm sure many of you forgotten it. I've forgotten it myself. But there is a relationship between insulin and potassium levels. Remember, we said that insulin, with one of the parts of that insulin secretion signal is closing of the potassium channel. So there is that relationship there, and what you can see is some patients that have hyperkalemia, even in the setting of normal blood glucose, that we give a bolus of regular insulin. It will basically shunt the potassium back into those intracellular stores, but it will lower their blood sugars. So you give insulin plus a dextrose bolus in those patients. So if they have hyperkalemia, you give insulin, you give dextrose, that will decrease the potassium, and then the two of them together will hopefully keep your blood glucose from dropping. All right, so that's regular insulin. NPH, again, is an older product, so it may come at a lower cost compared to other basal insulins. NPH is twice daily dosing. And there's some problems with predictability and variability between patients, but you have a patient that's been stabilized on it for years, they may be just fine on NPH, especially if they're willing to, deal with the extra administration that they would have to give relative to the newer basals. And then a word about Lente and Ultralente. These are older products. They basically rely on zinc insulin complexes to, again, increase its duration of action. Lente products really had close to a 24-hour range of action, but were very unpredictable. And they did peak a lot. So there were points in the course of the day where the patient's blood sugar would drop. They really had a lot of issues. They were really supplanted big time by Atlantis and its congeners. So basically in the early 2000s, you saw the drug products no longer being marketed, and they were withdrawn by the FDA as far as their approval in this, I believe, 2011. Okay, the rapid actings again, Lysprot, Aspart, Lysine, 10 to 20-minute onset, 3-hour duration. These are your mealtime insulins. You can use it also as a correction insulin. For example, you have a patient who you hospitalize, they may be brittle, but they are on a different meal pattern when they're in the hospital. So you may choose to do 4 times a day finger sticks, and then write orders for sliding scales to correct with one of these rapid acting products based on the results of that finger stick. So that would be the correction dose, and you would use one of these rapid actings for that as well. Like the question I've gotten earlier, most modern regimens will utilize one of these products with one of the newer basal insulins, have the mealtime plus basal combination. And I'll get to these this usage later, but rapid acting insulins can actually function as a basal insulin when it's given in patients that have one of these insulin pumps. Some of you may be familiar with those products. Basically, they deliver insulin literally over the course of the day as a tiny concentration through a catheter, and then you wear the pump and it gets delivered that way. Because it's constantly being delivered to the body, it will function as a basal insulin, even if you're giving one of these rapid acting products, right? So this is the preferred product for patients on an insulin pump. I'll talk a little more about that. Now, as far as the actual basal insulins are concerned, again, these are 24-hour durations with single injection. Three products that are, that kind of meet that definition nowadays is insulin glargine, brand name Lantus, insulin Dedamer, brand name Levomer, and then the Gluvet, which is Tresiba. And I talked about the modifications in terms of their amino acid sequence. Lantus really produces the kind of, even though it's the oldest of the three, still kind of the one that's really closest to your body's basal insulin. Dedamer is good. It binds to albumin, so there can be some variability there in patients with fluctuating albumin levels and changes in nutritional status. And also those who are on lower doses of Levomer tends to have a shorter duration of action, so it almost becomes a BID drug in the setting of low dose, low insulin management. So you have that kind of caveat to it, but generally speaking, on moderate to high doses of Levomer is a 24-hour drug. And then the Gluvet Tresiba pretty much is a once daily drug as well. Okay. Now here's another set of kind of caveats and modifications. Typically speaking, insulin is commercially available as U100 drugs, meaning that there's 100 units of insulin per milliliter. A unit of insulin is basically a standardized amount that will correspond to some amount of insulin in the body. So whatever moles or whatever amount of insulin makes a unit, and then there's 100 units per ml across the board, be it Lantus or Pizza or Novolog or what have you. Insulin syringes are calibrated to U100 insulin. The regular insulin syringes that you would just get by default, you ask for an insulin syringe, it's U100, meaning that each tick on a syringe, when you're measuring the dose, would be 1/100th of a milliliter, right? So it corresponds to 1 unit. So if you're delivering 30 units of insulin, you draw it up to number 30, what you're doing is giving 0.3 mLs of insulin. Follow? So it's U100, 100 units per milliliter. Insulin syringes are calibrated to that dosing. So if you're delivering 30 units, okay, you draw up to the 30 on the syringe. What you're doing in effect is giving 30/100ths or 0.30 mLs. But you, as a prescriber, you don't write for insulin in mLs. You say 30 units. Okay, the patient will draw it up 30 units. But the concentration, practical, in a practical sense, is 0.3 mLs. The exception is with concentrated insulins. Now, there are a couple of products that are available as either U200, meaning it's 200 units per milliliter, U300, which is 300 units per milliliter, or U500, which is 500 units per milliliter. These are going to only be reserved in patients with extreme insulin resistance. Okay. For every 100 diabetics you're treating, 99% of them will do just fine on U100 insulin. However, there's going to be some minority of patients due to their physiology that may benefit from higher amounts of insulin being delivered in a fairly smaller syringe. For example, if you have to give more than 100 units at a time, subcutaneously, it becomes a little bit of a limitation there. So in those cases, you can use concentrated insulin. Same amount of insulin being delivered, or, in theory, but in a smaller volume. And again, the products I have listed there, regular insulin does come as a concentrated product, U500. Lispro and Gludec comes in pre-filled pens, calibrated to U200, and then there's a U300 Lantus. So with concentrated insulins, you're giving smaller volumes, particularly for those with higher insulin needs. Now, in effect, what happens is that there's a longer duration of action of the insulin itself. Just the fact that you're giving more of it in a smaller volume, it tends to actually have a slightly different release profile. So you get a delay in the Cmax, a prolonged half-life. So much so, in some cases with patients on U500 regular, you could almost give it once a day without a basal. Okay, so it's the same product, but again, just the formulation of it being concentrated can also affect its absorption kinetics. And there are patients that will report improved glycemic control overall with concentrated. The main issue with this, as far as drawbacks, is the potential for error. Okay. You don't want to be that person that will make the mistake of either writing or administering it where the concentrated insulin is drawn up in a standard insulin syringe. Okay, that can be literally a five-fold error that will be maybe life-threatening. So basically, you have to acknowledge that risk, and a lot of health systems, hospitals have a lot of systems in place to avoid that and to work around it. I've worked in places where they just don't use concentrated insulins regardless of the patient's, being stable on it at home or whatever. But let it suffice to say there's a higher risk of error with those products. The U500 regular has been reported to cause a little bit more weight gain, and there may be an increased risk of hypoglycemia because it has a longer duration of action compared to regular. So those are the concentrated insulin products. Questions on that? Yes.
So when you write the prescription for the concentrated ones, you're still writing it in units, right?
Yeah, so you will say Humulin R U500,
Right.
and then the units, the amount of units. So you might give, say, 80 units twice a day or whatever of U500. The patient will now have a different set of syringes for that are calibrated for U500. All right, so that when they draw to 80, it's going to literally be 1/5 the amount of 80 units in a standard syringe. All right, but yeah, basically when you're dosing insulin, it's in units across the board. All right. Here are some activity profiles just to kind of overlay the 3 or the 4 or 5 products we talked about. Again, mealtime insulins will peak, within an hour or so, and then wear off. Regular is kind of a 12-hour product, peaks in around this period of time, 3 to 4 hours. NPH has a longer profile. In this graph here, it's about 18 hours, but again, know that NPH has quite a bit of variability intra-patient. And then the Dedamer glargine is your basal insulin that kind of almost looks peakless. Once it plateaus, it remains flat over the course of the dosing. All right, let's add some more confusion, shall we? Your premixed, your premixed insulin products. Okay, so here, these are products that basically have a biphasic mix. So you have insulin analogs, Humalog, Novolog, that are available as protamine lispro combination or protamine aspart and aspart combinations. Now again, recall that protamine is used to increase the duration of insulin action. So if you take protamine plus lispro, you now take it from being a very short-acting product to, a little bit longer. And then these are pre-mixed formulations. So in a vial, okay, 3 ml vial, U100, 25% of it is lispro, 75% of it is protamine lispro. Meaning that you give it, it will have one peak, that looks like that mealtime insulin, the lispro, and then another one that kind of has a not fairly long, a longer duration of action. So you have those pre-mixed combinations where they're either 75-25, 70-30, the ratio between kind of an intermediate product and a mealtime duration product. The older kind of OG pre-mixed insulin is Humulin 70-30, which is a premix between NPH insulin and regular insulin. Still kind of has a role maybe as again, a twice a day product. But really the advantage here is that we're not having kind of grandma mixing their insulin, maybe giving 4 doses a day. Here we can generally get them down to 2 injections a day, although the blood glucose control may not be as tight. It's sufficient, but it's easier to give than say 3 meal times and a basal, which is 4 injections a day. The insulin analogs, Humalog mix, Novolog mix, can be useful for prandial coverage in type 2 patients. And then I say probably the 70-30 Humulin, either for poorly compliant patients on basal bolus regimens. And I kind of discussed that in the next slide as well. Here. The typical regimen for both are BID. The insulin analogs you give with the meal, and the NPH regular, recall that regular peaks after 30 minutes, so you have to give that 30 minutes to 4 minutes. So that's your insulin mixes. And then we have the inhaled insulin, a freezer. To be honest, I haven't seen this thing kind of take off, but it's out there. It's a dry powder product, which basically uses the pulmonary delivery, and it's basically a mealtime insulin that when inhaled will give you a very rapid onset of action, faster than what you would get with subcutaneous delivery. Basically, it comes in these cartridges and in an inhaled product. They have a picture in the next slide, but they are pre-doses, either 4, 8, or 12 unit cartridges. You may have a patient that literally takes 4 units for breakfast, 8 units for lunch, 12 units for dinner, whatever. And that gets inhaled right at the time of the meal. Because of the pulmonary delivery, it gives you a 12 to 15 minute onset, 30 to 45 minute peak, and 180 minute duration, which is perfectly suitable for mealtime use. It's been noted to cause some mild coughing, but more significantly, it can cause bronchospasm and declines in FEV1. FEV1 is a marker, of course, of pulmonary function. And with the Afrezza, these can be fairly persistent, meaning after a couple of years therapy, we're not seeing it get better. It's almost irreversible, at least in some of the long-term studies. So you have that concern. And we should not be using it in patients with existing pulmonary disease. So this is basically a summary of the various insulin delivery systems. Again, the conventional insulin are the vials you get, put in the refrigerator until you're ready to use it. You draw up with a pre-calibrated insulin syringe and you administer subcutaneously. So that's conventional. Pen injectors are pretty cool. Here you kind of dial it up. The pen produces kind of a audible tactile clicking so that when you get to the dose, you can clearly see it through that window there. And again, that's calibrated units. And then you put a disposable needle at the tip. And once you dial up the dosage, you put it against your skin and you hit the button, it delivers the exact amount. That's, a fairly convenient way to precisely dose it. Doesn't take as much dexterity as the conventional insulin syringes. This here is the Medtronic insulin pump. Some of you may be familiar with this. This basically is a kind of a newfangled way to deliver insulin with those that have both a need for basal and mealtime doses. If you look closely, there is a chamber here that holds, some amount of insulin. And this catheter, when it's attached to the skin, will be a path where the insulin is delivered. This pump, as long as it has power going to it, can deliver a constant stream of insulin. Again, the preferred product here is one of the rapid acting insulins at Vicepro, Novolog, etc. Here, you're delivering insulin very gradually through that catheter under the skin as a basal. And then at mealtime, with the same hookup, the patient can dial up a bolus dose. So I'm about to partake in this yummy bagel, and then you deliver 8 units. Boom, it will then send a bolus of 8 units immediately, and then resume that basal delivery afterwards. So the insulin pump is a fairly convenient way. You don't have to draw dosing or anything of that nature. It's all there on the both basal and bolus. And then finally, the inhaled insulin, like I said, is a product that has these kind of pre-filled cartridges, pre-dosed. You put it in there, you breathe it in, and you will have, within 15 minutes, a blood sugar lowering effect that will be suitable for the dose. Those are the delivery methods that I'm familiar with that are widely used. Adverse effects for insulin include hypoglycemia. Okay. There are some immune reactions that can take place. Some patients may develop insulin allergy. Part of the pathology of certain types of diabetes, like the type 1.5, for example, is a immune-mediated effect. So you have that. And then there's immune insulin resistance, where it doesn't really affect the insulin itself, but some of the target organs. So you have insulin resistance there. We get some local effects, injection site reactions, like the dystrophy, etc. And insulin, because it's kind of a anabolic, will tend to cause weight. Drug interactions are here. Basically, these are drugs that can either decrease or increase the effects of insulin. You know, corticosteroids tend to be, we cover this in a little bit later in this, endocrine unit. Glucocorticoids tend to increase blood sugars. A lot of these other drugs will have effects on glucose metabolism and insulin, but, in total would end up decreasing insulin effects. We also get increased insulin effects from alcohol, alpha blockers, beta blockers, and so this is what I was getting at earlier in terms of the insulin regimens. Now, when you get into kind of the clinical coursework around this, you might get more into detail in terms of very specific dosing and timing and everything, but basically from my standpoint, what you will be doing mostly in your insulin acquiring diabetics is what's called a basal bolus regimen, meaning getting a once a day long-acting product such as Largine, Lantus, and then supplementing with mealtime Lispro or Aspirin. Ends up being about 4 injections a day with that combination. You can time it right at the mealtime for the mealtime insulin because of the fast onset. And kind of variations on that is the continuous insulin via the insulin pump, and you can bolus through the pump, like I mentioned. The sliding scale is when you have either hospitalized patients or otherwise institutionalized, or you can have self-managed patients that will administer on a sliding scale if they're really good with testing and correcting their insulins. And then the carbohydrate counting is again kind of another way. If patients are fairly sophisticated, they can modify their mealtime insulin based on the amount of carbs that they're administering. And this is what the basal bolus regimens will look like relative to the meals, with the top diagram being with one of the 24-hour long-acting basals of Lantus, and then the bottom black represents the NPH. NPH is used as a basal again. Now we have to do it twice a day versus Lantus, which is once a day. Dedamer, most of the time is once a day, but in Cajun, small doses of Dedamer, twice a day. So for example, you have a type 1 diabetic. They will require at least initially 0.5 to 0.6 units per kilogram per day. And of that, half of it is often a basal insulin and half is a bolus. So we have a 40 kilogram female with type 1. Half a unit a day is 20 units, 25 times 40 of insulin total. And then of that 20 units, half is basal, half is bolus. So the basal insulin, you can give, I made it confusing, Dedamer twice a day. 5 units twice a day gives you that 10 units, which is half of the 20. And then that other half, you have to break it down into 3 meals, right? So say you give 4 units at breakfast, 3 units at lunch, 3 units at dinner, whatever the case may be. Those would constitute the 3 bolus doses. That is rarely going to be what you end up arrive at as a long-term regimen. You kind of have to then play with it from there based on the self-testing and results you have. And if they are on it for a week, you bring it back in to follow up with a diary. You can look at those blood sugar readings and make adjustments based on that. But typically, in the basal bolus type regimen, 50% of your insulin units is going to be basal, 50% is going to be bolus. Again, I will defer to your clinical courses as far as how you actually go into the nuts and bolts of that, but this is just kind of an overview. All right, so any questions on pharmacology of insulin? That was kind of it. Yes.
There's an objective that says design a care plan. Does that include the sample, like the?
It will
The
be in
regimen?
very general terms. And again, because it's multiple choice, you will probably be asked to kind of discriminate, well, what makes sense from the four choices. But beyond that, no,
So we won't have to do like a conversion like we did with.
no, I'm not crazy.
On the slides, it said that it's preferred for, you said for DKA.
Yeah.
Why is that instead of rapid?
In the setting of DKA, basically you have someone that's emergently coming in for glucose, typically 600, 700, 800, 900s plus. Those patients, because of the acuity of it and frankly, the severity of it, the rapid acting insulins would not be sufficient. In those cases, we typically give insulin, regular insulin, but as a continuous drip. So there, we get it on board, it's going to last long enough to bring those sugars under control. And actually give us some predictability in terms of how that works. There isn't much experience as far as giving a drip for one of the rapid actings. So really, once we've had our experience with regular insulin in DKA, that's really kind of just been its role. And the rapid actings haven't supplanted regular insulin for that indication. Would it in theory lower blood sugar in patients with DKA? Yes. But as far as giving us the duration of action we need, it's not established. Because it is the most titratable. So, once, I mean, if you are delivering it through the catheter on a consistent basis, kind of on a gradual basis, it will look the most like your basal insulin secretion, your endogenous basal insulin secretion, when you give a rapid acting insulin through the so that's kind of my best answer. It will mimic that. Now, if you give regular insulin, its duration of action when given via subcutaneous is going to be so long that it won't be as titratable, meaning if you turn it down, it still has that, 5-hour duration or whatever because of how it's released through the subcutaneous route. It really isn't as appropriate for delivery through the pump for that reason. Make sense?
Yeah.
Okay, yes.
My question really simple. For the pre-mixed ones, how often do you give those? Is that once a day? Because it kind of has both
Generally twice a day.
effects. Twice a day?
Okay, the analogs, which is Novolog mix, Humalog mix, is with meals twice a day, breakfast and dinner. And the 70-30 Humulin N and regular mix, that is 30 minutes with 4 meals, because the regular is a short acting in that combination. That takes longer. So it's 30 minutes with 4 meals twice a day. A couple of slides here on insulin affordability. I think it's quite relevant. So, when this was discovered, 1923 was when the first process of human insulin was established. Basically, they isolated human insulin, and they found a way to do that. These researchers, Collett and Best, turned the patent for that process over to the University of Toronto, an academic institution, for $1. And this was a very kind of benevolent gesture so that this discovery can be made available to the masses to help this illness and do so at a reasonable or a low to zero price. And in that time, basically the patents have expired. We've sequenced insulin. We know what it is. And this process that was freely available to everyone has since been commercialized to the point where you have these private for-profit companies that are able to market insulin products and make huge profits off of it. Well, how did that happen? We have 3 manufacturers in this country that account for most insulin that's being used in this country. That would be Sanofi, Aventis, Eli Lilly, and Novo Nordisk. Those 3 companies will basically market all of the most popular insulins and insulin analogs that are used in patients today. And they have utilized this environment to basically set prices to the point where they increased tenfold since the introduction of those products, including Novolog and Lantus 30 years ago. Basically costs $7 to manufacture a vial of insulin. And with current efficiencies in the products and they have the sequencing basically again through recombinant DNA technology, you're able to program bacterial cells or sequence it in the lab. It doesn't cost much, $7 per vial. However, if you were to purchase one of these products, the standard 10 milliliter vial can cost you upwards of $350 for a vial of Lantus, wholesale, and up to $800 plus retail if you try to purchase it at a pharmacy. And in the public sector, Medicare D, the amount that the government spends on Lantus alone includes $959 million for Lantus vials for patients, and the prefilled pens cost $2.831 billion. So basically, close to $4 billion the government spends on Lantus, okay, across all of its Medicare D recipients in America. Interestingly, there are other top 10 drugs. 4 other top 10 drugs are also for diabetes, including Trulicity, Januvia, Jardiance, and our favorite, Ozempic. We get to talk about this week.
Yes.
So diabetes is really, really big. And then we talked about Hep C drugs. A couple of those drugs are high on that list as well. The direct-acting antivirals, which we talked about, are so super expensive anyway. So anyway, what has happened in the current administration is something called the Inflation Reduction Act. It's a huge bill that had all sorts of economic stimulus and inflation control measures, but really it's a stimulus bill. And one of the initiatives in there was to mandate that out-of-pocket costs for the patients who are Medicare D recipients would be capped at $35 a month. So that's great news for Medicare D recipients, meaning that they have kind of a predictable cost for their insulin. And really, from there's been some following the suit. Eli Lilly, which again is one of the big 3 in terms of insulin, they some months after that bill passed, stated that they will now reduce their out-of-pocket for most of their products to $35, even for privately insured patients. And even for uninsured patients, they're able to now use their patient assistance programs again to cap insulin at $35 a month. So really between the initial discovery of insulin and really up until last year, a lot of people struggled just to pay for this medication that we needed to live. Hopefully we're beginning to turn up the affordability issue. All right, I got a couple other products to discuss that are not insulin. First of all, pramlintide or Simlin. Okay, amylin is another of those beta cell peptides that is secreted from the pancreas. Pramlintide or amylin, when that receptor gets activated, reduces glucagon secretion and delays gastric emptying, thereby increasing satiety. It is a prandial injection given prior to meals that can help control blood sugar. It's used both in type 1 and type 2 diabetics. They serve as an adjunct to mealtime insulin and cause nausea and hypoglycemia. It slows the GI motility, so it's actually inhibiting gastroparesis. Not a major player in diabetes management nowadays, but again, it's one of these other products that is based on a pancreatic enzyme, specifically amylin. So basically, it's an analog of amylin. And then the other area I want to cover is management of hypoglycemia. This is going to be the main treatment risk amongst patients who use insulin. They either bolus themselves without really eating to offset that, or they may have taken too much insulin or whatever the case may be, causing their blood sugar to drop. You also see again with the circadian rhythms and how some of your insulin is processed throughout the course of the day, and how maybe some of the insulin products that do produce peaks some hours after dosing. So there's any number of reasons where a person on insulin can develop hypoglycemia despite having diabetes. Way back at the beginning of the year, one of the things we covered was with beta blockers. We said you can't use beta blockers with diabetics. Why? Because what happens when you get hypoglycemic, you have this hypoglycemic awareness. That is an increase in autonomic function. You get tremulous, your heart races, you get sweaty, all from the activity of the adrenergic system. He said way back when you knew a lot less about pharmacology than you know now, he said back then that beta blockers can blunt that effect so that you don't know that you're getting hypoglycemic after you get dangerous. So you do have that issue with beta blockers. You may actually have some patients with other sorts of reasons that they do not have hypoglycemic awareness from autonomic neuropathies or what have you. In any event, when your blood sugar dips below 65 to 70, you're in that hypoglycemic zone. And the one issue that happens, again, you get very panicky, get very scared and uncomfortable. Patients will tend to overcorrect. And 9 times out of 10, they will end up overcorrecting, leading to hyperglycemia. But if you have a patient that's conscious, that is hypoglycemic, they test themselves, oh, it's 30, 40, but they are alert and awake, they're able to dose themselves with carbohydrates. For example, 8 ounces of orange juice will produce 15 grams of carbohydrates, as well as they make these glucose tablets that patients can pop that contain about 4 grams of glucose. So this rule of 15 basically says that you should give 15 grams of simple carbohydrate in the form of orange juice, milk, or glucose tablets to correct that. That should bring it back to normal. but typically patients may not have that 15-minute patient, they feel the hypoglycemic and they feel an urgency to rapidly correct it, end up overdosing. I mean, it's okay, it won't kill them, but, it will often cause it to overshoot in the opposite direction. But anyway, the rule of 15 says that you give 15 grams of carbs and then you check in 15 minutes. You don't repeat that 15 grams unless they are still below 70 in that 15 minutes. Now, the other option for hypoglycemia is glucagon. So let's backtrack and talk about glucagon. Glucagon is a pancreatic hormone, and just like amylin and insulin, except here, it's secreted from the alpha cells of the pancreas. Glucagon is a shorter chain than insulin. It's a 29 amino acid chain, and it actually happens to be identical in all men. So you don't have like pork insulin, beef insulin, it's different from human insulin. Glucagon is glucagon, regardless of the species it comes from. In any event, what it does is bind to receptors on liver cells and basically produces opposite effects as insulin. So takes from the liver glycogen to glucose conversion, or you can get gluconeogenesis. Basically, the end result is increases in blood sugar. It also has inotropic and chronotropic effects in the heart. So it tends to increase heart rate and the cardiac output, inotropic effects. Therefore, actually has a role for beta blocker overdose for that pharmacology. So in an unconscious patient that's not able to run to the fridge and get orange juice, one of the options is to use glucagon for hypoglycemia. So here, if you, for example, have a loved one that's unconscious, and they have this glucagon kit available, you can inject a milligram of glucagon. That will basically emergently reverse the hypoglycemia if there are glycogen stores in the liver. Now, if you have a patient that's long-term malnourished and is hypoglycemic, look, glucagon, might not work because it relies on glycogen stores in the liver. Again, glycogen stores are finite. There's some amount of that your liver store, and if that gets depleted, glycogen's not going to work. The other thing about it is that it can cause nausea and vomiting because of how it affects smooth muscle. In an unconscious patient, what is the danger of nausea and vomiting? Aspiration. So you have to make sure that you lay them on their side and give glycogen. So that's great. Wow. So that's one way of doing it. In the hospital, more often than not, we're going to give dextrose IV. So an amp of dextrose is 25 grams in 50 mLs, which is 50, basically 50, the equivalent 50 grams. Basically, that is, just give it an amp of that, or you can measure a gram per kilogram. But it usually comes out to 25 grams solid. And that is infused in the patient, and that will, again, very predictably, rapidly correct it. Remember, we said last semester that physiologic dextrose solutions are D5, 5% dextrose. So we're basically giving concentrated dextrose about 10 times the concentration. D50 is basically 50 grams per 100 instead of 5 grams per 100. So there can be some irritation to the vein as it's going in, but again, if you have a severely hypoglycemic patient, that's usually what happens. So that's all I have. Any questions on continuing with dextrose? Those are going to be for diabetic patients who are on insulin. Although you can get hypoglycemic on oral drugs, it's not gonna usually be to the point where they get unconscious. All right, so these are patients who are prone to hypoglycemia and who can get unconscious, that there's some caregiver that can administer to them when they're unconscious. So it's a real small subset of patients that you'll be using glucagon for. But, you know, patients who are on oral drugs, yeah, some of the oral drugs can cause hypoglycemia, but except in cases of really severe intentional overdose, you're not gonna get to the point where they are gonna need glucagon. All right, so part 2 next week.